Well, welcome back, everyone. Welcome to College of the Atlantic, best place on earth. Woohoo! So my name's Sean Keeley. I'm a COA grad, and I'm also the executive director of the Summer Institute. And I get to do a lot of really fun things like this coffee and conversation program this morning. So a lot of familiar faces in the audience, but there's always a few new folks. So I want to take a quick moment to just say a brief bit about College of the Atlantic, in case you're wondering what this place is all about. We are a tight-knit community of learners and doers. We've been at it for about 53 years. And today we have about 350 undergraduate students all pursuing a degree, a Bachelor of Arts degree in human ecology. And we take an interdisciplinary approach to education. We examine and we seek to improve the world through bringing a lot of disciplines, different practices, different perspectives to bear on all kinds of things. And this morning's session is right in what I think of the human ecological wheelhouse, if you will, because healthcare, rural Uganda, Africa, to understand, to improve the situation probably takes all kinds of disciplines to bring to the table. So I'm looking forward to this conversation today. I want to welcome Jessie Stone. She's the founder and executive director of Soft Power Health and has been at it for over 20 years, working on the ground and doing incredible work, truly life-saving work in Africa and Uganda. Also like to thank Nadia Rosenthal for joining us this morning and leading this conversation. And Nadia has been a trustee for years, so she's really a part of this college, really helping to steer our academic program actually for quite a while, but cycled off the board recently, but is still very much
off the board.
Kicked off the board?
Too long.
All right, that's above my pay grade. We'll have to take that up with someone else. So a lot of people know Nadia from Jackson Lab, where she's the scientific director. Oh, don't tell me I'm going to get this wrong.
Fine. That's enough.
Oh, well, leading the way over at Jax, I will say. But I think of her as really a true blue human ecologist. And what jumps out to me in the conversations that we've had is that every conversation with you, Nadia, traverses disciplines and starts in one place and goes to places that I could not have predicted. I always learn something amazing, and I'm grateful for the chats that we've had, and appreciate your perspective incredibly. A couple of other things. I will try to kind of be brief here. This is sort of a special coffee and conversation today because it has a complimentary photography exhibit connected to it. So Eli Reichman, the guy with the camera trained on my face, in the back,
the camera, hiding behind the camera.
Eli put together a really wonderful exhibit, and it's to my left down this hallway and to your right, folks in the audience. When this session wraps up, I really encourage you to check it out on your way out. It brings the work of Soft Power Health to life. So please check that out. Eli's also here, as I pointed out, and we'll be happy to chat with folks. I will say that the exhibit's going to be up until, I think we agreed to sometime in mid-August. And so if you'd like to bring folks back to check it out, the Davis Center for Human Ecology will be open, and you can come and take a look. Okay, almost done. Silence your cell phones, please. Details like that. I've got a few little logistical items. So there's the cell phones. Oh, I want to remind folks that our Coffee and Conversation series will go on hiatus for 2 weeks. So next week we have our Summer Institute. We'll be under the big tent out on the lawn, and then we take a week off and sort of pick ourselves up from that week. And then we're going to return on August 12th with Karen Tilburg. She will be speaking about her book, Loving the Maine North Woods, with Professor Ken Klein. So that's coming. Lastly, I just want to thank everybody for their generosity to the college. This program, our Summer Institute, is free. It's open to the public, and that's made possible thanks to all of you, many of you. But if you're not a donor, I encourage you to take the plunge. There's no reason not to. It's a great cause. It's a great college, and we need your help. So all become donors, if you will, please. And I think with that, Nadia, I am going to turn it over to you for some conversation, and then we'll do mic running for the last 15 minutes and take some audience Q&A, including folks online.
Great.
All right, thanks.
So turn on my mic, although I can scream pretty well. Been teaching too many decades not to be able to project here. I've been asked to project. So what a wonderful morning. First of all, Jessie's brought the best weather of the entire summer.
It's not
Unbelievable.
you.
And so I'm going to be brief because I really want to get into the nuts and bolts of what we want to talk about today. But for those of you who haven't read anything about Dr. Stone, she is a medical doctor and a member of the U.S. freestyle whitewater kayaking team. Champion. So you'd think, well, how do these two parts of her life fit together? And they fit seamlessly because it was actually on a kayaking trip in Africa that she became aware of the disparity in healthcare between the developed world and the developing world, in that a colleague of hers on the trip came down with malaria. As a doctor, she treated him, but realized how complicated it would be for someone who didn't have access to the kind of medical care that we all enjoy. And this led to a journey that has now gone on for over 20 years. And it's an incredible story about the establishment of a clinic, of an extraordinary clinic in Uganda. It's called Soft Power Health. You heard from Sean. This blows my mind. Okay, the clinic started the way I started my lab, which is one doctor. Oh, well, in my case, it was a PhD, but in her case, it was Jessie. Two nurses, one lab tech, and they treated 10 to 12 patients a day. Okay, so just imagine that. Now, today, they treat over 60,000 patients each year with 100 or over 100 full and part-time staff members. So just imagine how that expansion has grown and what an extraordinary accomplishment that is in the middle of deepest Africa. So what are they doing? They are treating diseases like malaria, AIDS, other communicable diseases, but also the key component that really struck me is the focus on education. And we'll really hear from Jessie, I hope, a lot more on just how important that education is, almost as important as the treatments that they hand out. Now, we're in a funny time for us to be having this conversation because, as you know, US aid has been cut. This has created an enormous vacuum of support, threatening real access to life-saving care for millions of people, not just in Africa. And so Jessie's on the front line of this really dire moment. And so we're going to hear firsthand the challenges she's facing, looking at a way to provide critical health care in a country where there is one doctor for every 25,000 people. Just imagine it. Just to give you a sense of how different that is from where we're sitting right now. In this country, it's one doctor per 340, I think, or something like that. Yeah. So we're talking magnitudes of difference. And so the question is, how do you deal with these exigencies that we are facing today? And in general, how we go into the future? I'd just like to say that in my conversations with Jessie in preparation for this conversation with you, I was just struck by the amazing amount of optimism that she hangs on to through all of these really tough times. And specifically, I was really excited about some late-breaking news that I hope we hear about. Okay, but before we get to the late-breaking news, you've had a remarkable career, and it's taken you to places you probably didn't even realize you were going to end up. But I'd like to bring it back to local. I mean, you had your summers here at MDI.
I did.
We all know that there's a family involved here that really spent a lot of time doing what we all do, which is loving this beautiful island. And I just wonder, how do you think that had any effect on the way in which your journey unfolded later on?
Well, I've been thinking about this question, and I can kind of pinpoint it almost to one event. When I was 11 years old, my mother took me on a trip to the Allagash River, northern Maine, a canoe trip, and we went with Ann Maslish and Tony Maslish, and it was a parent-child experience, and that was just even to this day, I remember it so vividly. All the nights spent out, the days on the water, the moose that we saw grazing in the river at nighttime, all of the critters. And that was something, that planted a seed and a love of water. I loved water anyway, but this was like water in a wilder place, in a wilder spirit. And that started right here in Maine. And then the continued exposure and ability and great good fortune to be in the outdoors as much as I was. And then, I think that further cultivated the desire to explore and see new places. So when it came time to go to college, well, I'm going to the West Coast. I'm going to go to Berkeley. That's about as far away as you can go and as different as it could be. And then during my summers, I spent time working as a whitewater rafting guide. So very academic during the school year, and then out in nature when I was free to do that in the summers. And then, one thing led to another. I got a job offer to work on the Zambezi River in Zimbabwe. And I was like, first trip to Africa. That was very eye-opening, but it was a mix of whitewater and Africa. And then series of different things happened. I had a shoulder injury. I had a shoulder surgery that led me to medicine. Okay, what an amazing profession. Not necessarily becoming a surgeon, but just the idea of being able to help people and make a difference, work in that way. And so then medical school, and at the same time still trying to cultivate this, outdoor love and introduction to kayaking, whitewater kayaking. So I sort of fostered that along and then made it through medical school, kept taking time off to go kayaking. The dean kept saying, just graduate, just get out of school. I was like, okay. So finally, I had an opportunity to do this expedition trip to the Nile. So it was a kayaking trip. And it was, it was sort of, this was back in 2003. It was a place that was very not explored, especially from the whitewater point of view. So as you mentioned earlier on that trip, this colleague who had put the trip together got sick with malaria, and then I ended up having to treat him. And I said, wait a second, he's taking prophylaxis, he's sleeping under a mosquito net every night, and he got malaria. What happens to the local population? Are they sick with malaria all the time? What do they do about it? And then that led to doing a survey in the village where the clinic is now based. And after visiting 50 homes and interviewing people, we discovered that not a single person understood how malaria was transmitted. Nobody owned a mosquito net, but everybody was interested in learning about transmission and how to protect themselves and their families from malaria. And that was the genesis of how it all started. So I can really trace it in a very direct line back to that Allagash trip when I was 11.
I don't think I could do that. That's extraordinary. And what a beautiful way to weave two real passions together. So I can't help myself. I'm a scientist, and about, I don't know, 3 days ago, Jessie emails me and says, you won't believe what just happened. And she was in Uganda at Soft Power Health at the clinic. Just tell us a bit about the late breaking news, because it's seriously exciting, and it's a big deal. Well, worldwide, it's a big deal.
Yeah, I mean, I should poll the audience. How many people here have heard that there is a successful malaria vaccine available? Okay, so a few people have heard. That's great. That's amazing. So in the face of everything, with all the U.S. aid cuts and money not going to basic healthcare needs, we were incredibly lucky that we got distributed about 10 days ago now, the first successful malaria vaccine that we can roll out at our clinic. So we have it at the clinic, and we've already been able to administer it to children in need. So there are specific guidelines around giving it because vaccines are quite rare. And so we should be able to give it to any kid that needs it. But at this point, they're just specifying it for basically infants from 6 months to 11 months old. That's it. But people want it, and they're lining up to get it. So that's really great to see.
And not only that, but it gives you an opportunity to then go in and say, and while we're doing that, we're going to give you a few other things.
Oh yeah, well every Friday we have a free vaccine sort of opportunity for anybody who needs any vaccine at the clinic. And so we offer all kinds of vaccinations, just regular routine childhood immunizations. And now we'll have the malaria vaccine to add to that. But we also offer vaccination in our outreach programs, which we'll get to. But yeah, so we make it very available because vaccines are scarce for most people. I mean, we treat measles at our clinic, we treat tetanus at our clinic. Those are real diseases that have real serious consequences. You can die from them. And, people just aren't able to get that basic vaccination that they need.
What an incredible role model this is for, the rest of the world where these horrendous pandemics can just take hold. And given that we've all just been through one of these firsthand, it's not something that you can just sort of read about in the newspaper. I think everybody is much more hypersensitive about this issue of when's the next one going to hit, what's it going to be, is it going to come through transmission from another organism like a bat or another kind of organism. And obviously with people who are living in rural communities, the exposure can be very, very direct. It's not just something where a bat flies over your house, you're eating them. So among other things.
You're eating them and they live in your house.
And they live in your house. So so this led me to start talking to Jessie about what it feels like to be on such a front line when, the rest of the world has actually experienced one of these pandemics, and how do you prepare for it? How, in the context of a much, much more challenging situation where people can't just go and get, down to the hotel as I did and get my COVID vaccine.
Well, I think in a word, you don't prepare for it because you can't prepare for it. In a resource poor setting, every day that you're treating patients is kind of a long emergency because you're under-resourced. You have so many patients that need care. We don't turn anybody away. So on an average day, we can see at our clinic between 150 to 250 patients a day. And there are, maximum 7 doctors at a time working. So that's a lot of patients for one doctor to see and treat, plus, all the laboratory work and the nursing work and the dispensing work and, all of that. So each day is like its own little mini, reaction to the need. So and in terms of resources, like for pandemic preparedness, you just have to take it as it comes. It's not, it would be very difficult to prepare. The infrastructure isn't there. The resources aren't there. And in some ways, this is going to sound crazy, it's kind of good because there's limited information. People don't have too much information. And there's really not much misinformation because people just don't have the technology for that.
Yeah.
So,
but the information is so important. And that's where the whole concept of education coming along with the medical treatment is so important. So, so tell us a little bit about that and the whole sense that grassroots is really a key component to this.
I think it was just initially discovering what people didn't know about malaria was really eye-opening to me because I think we all make this assumption that if you live with the disease, you must understand how it works, just automatically. But that is really not the case. So we started asking people, like, for example, how do you think you get malaria? And people would say, eating too many mangoes, standing in the rain, the wind. And I mean, I'm not making this up. If this hadn't really happened, I wouldn't be sitting here and telling you this. But so unless you have that basic education about how is disease transmitted, how is it prevented, you're going to go by what your neighbor tells you or, what you've observed yourself. Like it must be, your own cause and effect without really understanding the whole process of it. So we've gone out of our way at Soft Power Health to run 6 health education outreach programs in addition to what we do at the clinic, and those address specific health needs. So we run one for malaria, that's our longest one, that's an education prevention outreach program, one for family planning that explains conception plus contraception and offers that in the field, one for malnutrition because malnutrition is a huge problem, in particular protein malnutrition. So that explained to people, how do you create a nutritious meal? I mean, people don't know what a protein is or, versus a carbohydrate or a fat or a fruit or a vegetable. I mean, it's all just one thing. Yeah. So just explaining that and then helping people to realize they can create that from what they grow within their own gardens. Very helpful for them and health improving, life changing. we also have a domestic violence outreach because domestic violence is a big problem in Uganda, and as it is all over the world. We have a physical therapy outreach because many patients who need physical therapy, which is another very scarce part of medicine, can't actually access it at our clinic. So we go to them. They can't physically move. So we meet them where they're at. And then the final thing we do is we have an organic gardening outreach, which complements the malnutrition work. So it helps people not only understand how to create nutritionally important garden foods in one meal, but also how to do it to replenish the soil and work with what is available locally. So though you can go to the local market and buy the most toxic pesticides that you can imagine, we don't want people to do that. We want them to understand the consequences of doing that.
Exactly.
So all of those things, and they focus on education first, real education, and then after that, prevention, and then follow up, and treatment. So it's like 3-prong model.
Incredible. We were just talking a little bit about the concept that you really need to make this a collaboration. And I'm just wondering if you could tell us a little bit about who your staff members are, where they come from. Are these people who were trained in Africa, or did they come back? And you're just one person, you're superhuman, but still.
No.
And so how do you actually make this into a collaboration? But we were talking about the fact that you charge a little bit of money for the mosquito nets, that you engage people and bring them into the education. Just tell us how that all works. 20 years of this must have been quite an education yourself.
Well, the whole process continues to be very educational for me. I'm always learning, but in the beginning I was asking tons of questions, and I was the first doctor that I met in Uganda. I went constantly to him to say, okay, what do we do next? How do we do this? What do we do? Anyway, our staff today, he then came subsequently, the one doctor that I was asking all these questions to came and worked for us for many, many years and became our clinic director. But our staff is entirely Ugandan. So Ugandan doctors, nurses, laboratory technicians, physiotherapists, dentists, local educators, drivers and accountants and human resource people and, the cooks, the cleaners, everybody,
Wow.
So it's Ugandan. And everyone was educated in Uganda at Ugandan universities. And some people have traveled abroad for further degrees if they get an MPH from the London School of Hygiene and Tropical Medicine. They had that opportunity. They would go, but they always wanted to come back. So it wasn't like the brain drain you think of. But the idea of collaborating, I think, is the only way that you can get anything done successfully. You've got to start with the grassroots of asking, what is it that people need? And then how can we work together to do this? I think very often where aid has failed is that somebody has a brilliant idea in Washington and wants to apply it, but they haven't really assessed the situation. Like, is this even going to work? And you have to be out in the field, and you have to be on the ground, and you have to find out, and you have to engage local people who understand how things work, what the culture is, and you have to work within that.
Right.
And that's the only way things work. And then when you do that, it does work. It's kind of incredible.
Yeah.
So,
Obviously.
it's really, it's wonderful to see that, like now I'm happy to say I'm kind of like, I am not needed. I'm like extraneous. I love to go, be there, and do what I do, but I'm not needed to be there for everything to work. The system of charging a little bit for mosquito nets, as you mentioned, or for the clinic service is really important because it's an investment by people in what we offer. It's value for the service. And we make a point of making it within reach because we want to make sure that the people who are among the poorest of the poor have access to that care.
Yeah.
But even the poorest of the poor have a little bit of something to pay. And so there is, I should say, just in that context, there is a subset of patients and people who have, through whatever circumstance or situation, health condition or social circumstance, can't pay. So we do subsidize fully a small
Yeah.
percentage of patients, but 90% of our patients pay and can pay that small fee.
That's
So-
really, and that's to me, it was very revealing about how you actually manage a situation where you're really trying to change a culture in some ways, or at least influence a culture or enrich a culture. And you can't just do that by coming in and dumping stuff on people.
No,
It just
you
doesn't
can't.
work.
And in Uganda, you know, there's also a huge history of corruption. You know, corruption is a major issue there. And so you have to be consistent with what you do and you can't waver. You know, you got to stick with your program. And, you know, and so we've been able to kind of like navigate that and, you know, not be a part of that. But everyone is so used to it. They just are thinking this is how things work. And
Yeah.
that's the problem with the government healthcare system. It
Yes.
is so corrupt. It's supposed to be free for everyone. So if you showed up at the government healthcare facility, you should be able to get any kind of care that you want and need. But it absolutely does not happen. And so if you don't have a lot of money, you won't get care. If you don't have money to pay up front, you will die waiting for care.
So
You know?
how does the government view soft power health? How does that
They
relationship?
really like us, actually.
That's
'Cause
great.
We help them look good. We help them look good. We report all of we're part of the medical delivery system for our district, the district of Jinja in Uganda. And so we report all of our information, you know, everything about our patients, our outreaches goes to the district medical office. And so it helps the whole of Jinja district look good. And so they like us. Yeah.
That's wonderful.
Yes, it is.
Unexpected.
It is. You know, we definitely try to, you know,
Yeah,
fly below the radar, but we, you know,
Yeah.
like what we're doing.
that's amazing. So, I just have to ask you because I'm a geneticist, and obviously, I don't know if you are aware of the fact that Africa as a continent has more genetic diversity in the various cultures, human cultures that exist than anywhere else in the world. And it's because, of course, we all started there. So we're in some ways all African. And that means that the amount of information we can understand about humans and how humans respond to pathogens and diseases really has, of late, become an enormously exciting area for genetics. And now that we can sequence genomes and all of that, we get a better view of how extraordinarily rich the variation is. And when we were talking about this, you said, yeah, and by the way, I'm so amazed at how resilient the African cultures are to disease and to a whole bunch of other sort of challenges. And they're sort of better than us. They do a better job at living in what is a much more challenging environment.
Yeah, there's no doubt. I mean, the ability to survive in every way, in my observation in Uganda, is so far past ours.
Yeah.
And because they are just assaulted with so many health challenges and survival challenges from the time they're born. And, you know, just surviving past 5 years old, and your immune system is developing from 0 to 5, essentially. And if you can survive past that, you know, you are just a genetic specimen. I mean, you're incredibly adapted to your environment, and you are, you know, superhuman.
Yeah.
You know, I mean, it's just observationally the kinds of things that people have survived with, you know, presented many months after, you know, an automobile accident with a horrendous injury and infection, and not died from that, you know, and the ability to, you know, live with a certain disease for a very long time and not die from it, which would have killed us off here a long time ago. You know, it's extraordinary. So I absolutely believe that. And it sounds a little crazy, but I think if anybody in this room saw it in action, you would understand exactly what I mean.
Yeah.
So it's remarkable.
I hadn't thought of it that way. So it was a revelation when you said that. It was really interesting. But just to get back to the current situation, we were talking about the fact that right now, so many programs have been affected by the USAID withdrawal, and the fact that you know, now you were talking about how there's no Ebola program for
Yeah.
tracking. There's huge gaps in what you have been relying on for the last 2 decades. So tell us a little bit how that's going. Talk about long emergency.
Yes, it's sort of the longer long emergency. It's so in Uganda is one of these countries that had very successful programs funded by USAID specifically for HIV, among other things. HIV, all kinds of testing, counseling, treatment was free for Ugandans if you were diagnosed, and you could be followed up. And millions of Ugandans have been kept alive on these programs, and they've been woven into the government health centers. But also there were plenty of standalone clinics that did this.
Yeah.
So they were remarkably successful. And now what's happened with those programs is all of the funding has been cut except for treatment of known HIV positive people. So no new diagnoses, no ability to diagnose, no counseling and treatment, no education. All the education component has been totally cut. So that is definitely, I mean, you can see it already having major consequences for people. Our clinic is much busier than it's ever been. We're treating anywhere between, 300 to 500 more people a month who are seeking care where they would have been going to other facilities that were open.
It's really pushing the
Yeah,
boundaries.
Yeah, no, definitely. And then the other big thing was tuberculosis is still a disease that's very much alive and well in Uganda. And every time someone is diagnosed with TB, they want to test what genetic strain it is of TB because they're trying to find out what resistant strains of TB are out there. And because it is, as you well know, notoriously difficult to treat.
Yes.
And so the whole system of genetic genotyping of those strains of TB has been stopped. And there's no contact tracing that goes on for when you're identified. And as you said, for Ebola, we used to work very closely with the CDC. CDC's gone from Uganda, so there's no, like, there used to be daily updates, like, okay, there's Ebola outbreak in X district and this many people and whatever, gone. So there's a lot of stuff that has just kind of evaporated.
I don't know if any of you were at the Nirav Shah Summer Institute talk a couple of years ago where he was talking about, he showed a whole video on how they are following bats around Africa to try to figure out where the next outbreak of a pandemic that might be carried by these bats would show up. So they're just following the bats around. And he was so articulate about how much this was a real focus for the Center for Disease Control, which he ran for several years. And just the idea, I just wonder what he's thinking right now. I mean, this is just, it's beyond.
We should call him.
I think we should. Yeah. Yeah, he's back in Maine. He loves Maine.
Oh, great.
Yeah.
Okay. Well,
Yeah.
then maybe that would actually be possible.
Okay, well, that's an idea. Let's talk about it afterwards.
Yeah.
That's great. Yeah, so you're doing the sequencing. You're doing the actual
So basically, we have been asked locally, the district medical office came to us and said, you're here, you're busy. We'd like to give you this gene expert machine to do the genotyping for tuberculosis. And so we've taken that up. So that's another thing, like, we have absorbed and we're doing it. It's stretching us, but we're doing it because it needs to be done. And otherwise it's not going to get done.
Yeah.
And it's really critical.
So you're now running a science lab as well as
yes,
an
education
education
lab within
center
our lab.
and patient center and everything else.
Yeah. Yeah.
So what's a day in the life of Jessie like? I can't even imagine. I mean, how many things do you juggle?
You should ask my mother. She's in the audience. No, I'm just kidding. No. I think, it depends where I am.
Yeah.
But a day in Uganda is usually trying to squeeze in as many possible different things as I can into a 24-hour period.
Yeah.
Which is great because it's a lot of really good things, so it's visiting the clinic, visiting outreach programs, going and visiting patients at home, meeting with students, meeting with volunteers. We have, like, right now in Uganda, we have Masters of Public Health students with us. We have a group of volunteers who are with us. We had very luckily, this is so encouraging to me. We had people coming to report on the effects of the USAID cuts. They wanted to. One person who's a journalist is doing a big story on it. Another one is making a documentary about it. So it's heartening to me because people want to get the word out and tell what's happening. But seeing all those people, trying to show them what's happening, trying to share that experience, make sure the clinic is running smoothly, everybody's happy, which it's a lot of different facets. There's medicine, there's people, there's all kinds of stuff going on.
Well, getting the word out, that's a critical thing right now, because presumably the sort of the portfolio of support that you have for this amazing clinic you've designed is not as rich as it was. I mean, with USAID pulling out, it has big ramifications, both indirectly and direct.
It definitely does, because though we were never directly supported by USAID, we received family planning supplies from USAID, which thank goodness the United Nations Population Fund has stepped in for this year to commit to giving us those supplies. But that's, so for the rest of the year, we're good. I don't know what's happening next year. But, the fallout from all these program closures is just many more people looking for medical care that they were getting,
Right.
And some of these programs that we're running, long term, 20, 25 years. So people were very used to getting the HIV care. So that was really, for many people, it is a death sentence. And so it means we are just receiving more patients. And, so we're consuming more medicines, laboratory supplies. We need to hire more staff to help manage. So it is, it's a need. We need to raise more money.
Yeah.
So
you're growing something in a time when everything is being withdrawn. So it's
So so that's that's a tricky thing. Like right now, as you mentioned, we treat around 60,000 people a year, and that's at the clinic and through the 6 health education outreach programs. We do all of that on a budget of about $650,000, and that's it.
God.
And it, so that's about $13 a person. So it's really good investment.
Certainly is.
But we do rely on support. So that's how we keep going. And so yeah.
Wow. So just one last question, then I want us to have a real conversation and not just me peppering you with things I want to know. So these days, you're a physician, you're a visionary, you're a fundraiser. What's the most interesting question that sort of pops up in your mind on, when you wake up in the morning, other than, oh my God, how am I going to get to the end of this?
There's that, but then there's like the tackling other issues. Right now, we're trying to address the issue of cervical cancer. So cervical cancer is almost eliminated in the United States. It's been eliminated in Australia. In Uganda, it is the biggest cancer killer of women. And so no screening is available. There's no such thing as a pap smear. But there is the HPV vaccine.
Right.
So we have it, and which is another small miracle that we actually have the HPV vaccine, and we roll that out in both at the clinic and in our outreach programs. And there's very positive uptake of that. So that's one prong. But again, because it's a limited resource, we can only administer it to girls of a certain age. We can't do girls and boys. We can't do, the recommendations are boys and girls 10 to 40 years old in this country to
It's
receive.
a virus. It's one of those wonderful realizations about cancer is that, at least in the case of cervical cancer, it is a virally transmitted disease, and therefore a vaccine can actually keep you from getting sick.
Exactly.
Sorry,
exactly.
and just in case that wasn't clear.
Yeah, so it's a good thing to say, because I get in my medical brain and forget that, got to say that. Anyway, so how can we impact the population so that we can get the vaccine out there, educate them, and then reduce the burden of this disease? So that's something my brain has really been going a lot through.
Yeah.
There's another person in the audience who's been helping me think about that a lot. Where is Dr. Laura? Are you here, Dr. Laura? She's supposed to be. There she is. Dr. Laura McIsaac has been to Uganda several times with her husband, Price Lowenstein, who's anyway, she is an OBGYN who's been helping me think about how we're going to tackle that.
That's
And so
fantastic.
yeah. So those are things I wake up in the morning and think about.
And thank goodness you do. Anyway, let's open it up, Sean, and let's hear what all of you would like to hear from Jessie about.
Great, and I'll just ask the people speak right into the mic so the folks online can hear.
Hello, thank you very much. I'm a PEPFAR alum, so I'm glad to hear what you're doing. Question on leapfrogging in terms of health technology. There's a lot of mobile phone penetration in Africa. Some health systems in Africa have done much more with electronic health records in terms of surveillance, outreach to patients, the continuum of care. What opportunities are there to use technology maybe even better than we're able to use it here at home? Thank you.
Oh, that's an excellent question. Thank you for asking it. So one of the issues is, technology has the potential to do a lot of really fantastic things, like you're saying, using phones. But it is predicated on this one thing that is not readily available where we are, which is power. And so if you can't charge a phone and you don't have a smartphone, which the majority of our patient population does not, then it's not something that we can use. So it has the potential in more developed areas, more urban areas, and for wealthier communities. But a lot of our patients, if they're lucky, they have a little flip phone or one of those, old burner phones. And, they have to send it to a charging station to get charged. And they have to, buy minutes to put on their phone to make calls and texts. So it's like, we're not there yet for that population of people, but for some populations, it can work fantastic. So we're talking about really, much more, less sophisticated living, if you will, But excellent question. Thank you for that.
And there's one over there afterwards, Sean.
Hi, huge kudos to all of your work, tremendous. But I wonder about all the rest of the people in Uganda. So do you have any plans, not that I want to give you more work, but do you have any plans to have other satellite clinics or a hub and spoke type of approach?
That's an excellent question. And I always have been trying to share our model because I'm not proprietary about it. It's very simple. It's very really basic, but it works. I can't, I don't think I could take that on, to be honest with you. If somebody came to me, if, I don't know, Jeff Bezos showed up and was like, here's $40 billion, go to town. Yeah, okay, then we can talk, but it doesn't have to be that much money. But,
let's ask anyway.
But it's just the amount of you really want to make sure that that money goes where it's supposed to go, that it's going to the grassroots, you're reaching those areas. So to answer your question, collaboration is also the way forward. We work with a lot of other organizations, creating a bigger net and a bigger spread to try to catch a lot of people who would fall through the system otherwise. Other parts of Uganda, we have collaborated with people in different parts of the country to share information, share resources. It's a big thing to tackle because when you're looking at one doctor for 25,000 people, it's such a scarce resource. So you kind of have to, it would be wonderful to say that we could recreate soft power health in other places. I'd love to be able to do that. Right now, I can't do that, but I'd love to try. So maybe in the future, who knows?
Hi, good morning. Thank you. You mentioned that most people don't have power. So I was curious how the clinic is powered and if you see that as like an opportunity for partnership of having like a distributed solar program or something. I know a lot of countries in Africa, there's been programs to help people to power their homes with, even just a LED light and
no, that's a great question. And Our clinic is entirely powered on solar. So yay, thank you for, and thanks to that, we can have electronic medical records. So there are the Nile River, which is very close to our clinic, had fantastic white water. It still has some, but a series of very large hydro dams were built for electric capacity to be generated and distributed throughout the country and to the neighboring countries. However, the distribution has not happened, and for a number of the dams, one in particular generates no power. It was a complete boondoggle. It was badly constructed, and the engineering was crap. And the materials were bad. So in a few words, it doesn't work. So solar is the only way forward, really. And there are a lot of individual solar systems that people can purchase and use at home, and that is definitely the way forward. No doubt about it. It's the only way forward, really. So thank you for that question.
I'm going to go all the way over to the side here.
I was following the rescission process in the Congress that took place last week, and the Food for Peace program was saved, while most of the other USAID programs were rescinded. Food for Peace basically provides price supports for the American Midwest farmers and sends surplus food to Africa and other places for use in development and relief organizations. The area you're in, Jinja, which I had the pleasure of hitchhiking through about 55 years ago.
Excellent.
I remember it as having a huge, absolutely huge sugar plantation, the Madhvani
Yes.
sugar
Still there.
plantation. I remember being on the back of a pickup truck, and we got to this thing. They said, "Oh, we're going to go through the sugar plantation." I thought it was just kind of like going through a blueberry field here in Maine. And a half an hour later, I was still in the plantation.
It is. It's like its own country within.
Yeah.
Jinja.
Doesn't the Jinja district have the potential to be a breadbasket for many parts of East Africa?
That's a good question. I mean, I think part of the issue is there's a large population in Uganda. It's one of the reasons why there's such a bad malaria problem there, and the large population is growing, and so it's very hard to have in families. The one thing that Ugandan families have is land, but that land is distributed among the children. And so if you start out with a large plot of land, it often gets broken up. So what most of the time happens is people have their own small individual, subsistence gardens, if you will. So everything does grow there, and with climate change, the predictable rainfalls have changed, but it still does rain, and you still do, have a dry season. It's very fertile. It has a lot of potential, but it also has, a large population subsisting on the land there, in kind of smaller gardens, if you will.
My real question is, what do you think of using Food for Peace and other imported food programs in situations like you're at?
I mean, the good thing is in Uganda, luckily, there are certain areas where they do have to import food, but not for the majority of the country, because in the majority of the country, they can grow their own food. So that Uganda is lucky in that respect. It has other challenges, but I mean, a lot of the imported food is going, to a refugee camp or an IDP camp or something like that. So not necessarily for distribution, amongst the population. And that's a good thing, because people, as I said, they can grow their own food. And I don't know if you had a chance to visit the Central Market in Jinja, but that is a very eye-opening experience. Fun. There's just more different kinds of fruits and vegetables than you'll ever see anywhere in your life. So, yeah. I don't know if I answered your question or not, but.
Right here.
Thank you very much, Dr. Stone, for this conference. I wanted to ask when it comes to community outreach, because I know that a problem is maybe there is the hospital and you're able to help the people surrounding you or in the close proximity, but how do you reach the people that live an hour away, where the roads aren't that good or the transport is expensive? Ambulances, are you able to run the ambulances for maybe immediate
So-
care?
So that's a very good
Thank you.
question. Our community outreaches, we go to the communities. So we bring, health education, prevention, and in some cases treatment to rural communities. So we drive, we use our vehicles, our drivers, our nurses, our staff of the clinic to go to these places and run the education programs and bring the supplies with us. If somebody needs medical care, we will refer them back to the clinic. And if they can't get there, we'll help them figure out a way to get there. But again, there are no emergencies in Uganda. There's no emergency medical system. There's no ambulance call out. That does not exist. So if somebody comes with an emergent problem, then depending on the nature of it, we'll try to manage it at the clinic. Otherwise, we have to refer them to the Jinja Hospital because we don't have an operating room, for example. We don't have that kind of infrastructure. And so it's very much emergencies are managed, sort of the best way you can, which is definitely not how they're managed here, thankfully for all of us here. Thank you.
Good morning. Thank you very much for the incredible work both of you do. My question is about generational uptake. So you have a cohort of people who for 20 years have been coming to your clinic. So how do you engage with the ongoing generations so they understand the helpfulness of engaging with a clinic? And do you work with schools at all?
So the patient population that comes to the clinic is multi-generational. So it's, we have a 20% of our patients are pediatric patients. So we have a lot of kids. And then we have everybody in between up till, end of life. So we'll see anybody and everybody who comes. And then essentially reputation gets out into the larger community, and the word kind of spreads. Okay, this is what they offer, this is what they do, this is the service. They charge a flat fee that covers the consultation with the doctor, the laboratory services, and all their medicines. And it's reliable, it's good care. They'll be nice to us, which is not the tradition in the Ugandan government healthcare systems. People are very much like harassed when they get to the doctor. They're like, why did you let your child get so sick? Things like that. So it's not a nurturing culture of medicine in that respect. But the other thing is through the outreach programs, because we're, again, engaging all different age levels. So there's a big knowledge, bracket out there. And often we will do education sessions on a school grounds or near a school. So we do engage with schools. But a lot of the people we're trying to reach and do reach are people not in school and not able to have a formal education of any kind, because there are a huge number of uneducated people who don't have access to school at all, like zero. So we want to reach those people too, because they often end up being amongst the poorest of the poor. So does that answer your question? Okay.
Well, your dedication and skills are really amazing and encouraging. And I'm wondering what it would take, or if it's possible, to replicate your success in other locations, particularly other countries. If Nadia has to clone you first, or that would be good. That's good. Or if you've met people who have the drive and the skills you do, or if there are other fertile places.
The ground, yeah. There's need to introduce all of you to Dr. Marguerite Yonker. She's a Danish doctor who runs, she runs a partner organization we work with called Rays of Hope, which is a hospice organization in Jinja that provides pain and end-of-life care for patients. You know, they serve a huge area. She's one of my dear friends, and she's been doing this kind of work for her entire life. She and her husband have retired to Jinja, and she's going to work, you know, forever doing this. But it's yeah, I mean, all the people that I'm lucky enough to work with over there are like me, or, you know, much more than me. You know, they're doing this because they really enjoy it. They get a lot of satisfaction out of the work, and they see change, you know, that's possible, like positive outcomes. You know, it's not all gloom and doom. There's a lot of joy in it. There is, you know, there's a lot of success. I wouldn't be still doing it if it weren't like
Well,
that.
do you see other fertile places where your seeds could grow in other countries?
I
In
mean,
Chad or
you know,
Botswana or?
I feel like I can't answer that question because I don't know those countries. You know, I think there's so many different factors that go into what makes something possible. Like when I was a medical student, I worked at a hospital in Kenya that I loved, but the culture there was very different than in Uganda. You know, just the medical culture and everything. I'm not sure, you know, that what we do in Uganda could work in Kenya, and Kenya's right next door. You know, I think it could work in other parts of Uganda, but it's, you know, it's hard for me to say. There's just the cultures in these different countries are very different.
Thank you.
Sure.
And Sean, there was one more here.
You had a quick one?
Quick one. I just wondered about foundations that might be supporting your efforts.
I'd love to know. And you have
You got one?
She thinks it would be a good idea.
great idea. I'm totally open to it. No, we have a few foundations that are supporting us. They're mostly, you know, family foundations and things like that. But it is a lot of individual donations, and any donation really matters to us. Small, large, it doesn't matter. Every dollar helps us. So it's yeah. We are not selective. I'm very open to foundations. I will not discriminate against any of that. So yeah, I don't know if I answered your question, but
Great. Well, one question that came online, very simple, and then we'll make this the last, from an online audience member asked if you could talk about the name of the organization, Soft
good
Power
question.
Health.
Yeah.
What's that all about?
Okay. Well, I think by now people have probably heard of, you know, a lot about the word soft power. But the idea being that, you know, if change is going to come in this world, it's going to come through softer means, you know, not through military might, but through education, through, you know, sort of collaborative work, working together with people, building goodwill. And I think that is really sort of what we have been trying to do and doing for the last 20 years, is collaborating with people, focusing on education and prevention as well as treatment, and trying to help people to help themselves, you know, and also break out of this like dependency cycle, because a lot of foreign aid has created a lot of dependence. And this is more like helping people to be independent, giving them some basic tools, helping them, you know, get started, and then just watch them do what they do so well. And that's the best way forward. So that's really where the soft power name came from.
Great. Well, that's beautiful. Please join me in thanking.
Oh, good. Oh. He's clapping for you. Yes. You asked such great questions.
Well, thank you both so much. That was incredibly insightful.
Thank you.
And I think you'll stick around a little bit. So if folks want to chat, and I mentioned earlier that Eli Reichman's photography exhibit is just down the hall, and there's a bunch of these around. This is 2 decades of transformative healthcare in Uganda. Tells the story a little bit of the story. So thanks everyone for coming out,
Yeah.
and we'll see you next week at the Summer Institute. Enjoy the day.
Thank you.